July. So when it comes to general measures, the most important, the greatest tool for preventing infection for any of us, be it our pregnant women as well, is social distancing. So she needs to disinfect her surfaces to reduce fomite-related spread. If she's working outside the home, which most women are not, but it's preferable to work from home, it's necessary to keep a distance of at least 1 meter in various necessary interactions, avoid non-essential travel. We do still get a lot of women who are traveling within the country to have their delivery at their hometown, so that's important. Avoid gatherings and functions, especially in our scenario, in our cultural practices where they do celebrate the 7-month milestone. So you should avoid or limit it to a few people and minimize visitors who are coming to meet the mother and newborn after delivery. These are very sensitive issues, but we have to make sure that these are followed as well. And with Do the 5, which WHO recommends, is still very, very useful and helpful, provided all of them are followed. That is, you stay at home, you frequently wash your hands, cover your mouth and nose with bent elbow or tissue, especially when you're coughing. Avoid touching face, eyes and nose and mouth with hands, especially when you go out and come back. Don't touch your face without washing your hands, and maintain a distance of 1 meter. And it's mandatory to use masks at all public places, depending on what type of mask, depending on who you are, but it is mandatory to use masks at all public places. With dietary advice, there is no particular diet to improve or treat or improve the immune status as such. And there was a worry that if you eat meat, that could increase your risk. But again, there is no study to show that consumption of meat will increase your risk of acquiring coronavirus. And the general advice would be to have a high protein diet, vitamins, and micronutrient supplementation. But there is no specific diet as such for our pregnant women. When it comes to organization of services, government institutions have already been advised regarding preparation and conduct of regular mock drills by advisories. And basically, public and private health sectors should essentially divide themselves into non-COVID and COVID facilities, because still a significant proportion of maternity care is provided by the private sector, and it needs to continue to provide these services so that our public health infrastructure does not get overburdened. So we need to be prepared and ready to face all these women. So again, in the FOXI GCPR guidelines, it is very nicely categorized as to what we need, what the facilities need to be done in a COVID maternity hospital in a private sector and non-COVID maternity hospital in a private sector, where it says there has to be a separate building with multiple exits, a separate dedicated labor room and operation theater, medical facilities where we are equipped to manage maternity care, and then should have adequate stock of PPE where to cater to all our women depending on our requirements and backup facilities. So what are the key issues in antenatal care? Basically, it is to optimize the number of antenatal visits or postpone these antenatal visits or increase the interval so that they are not seen so frequently, but yet seen. For the low-risk, asymptomatic and uninfected women, the recommended strategy is to conduct antenatal care visits by phone or video call, supplemented with whatever monitoring you want to do them at home. We can shorten the duration of antenatal visit, and when they come to the hospital, limit the visitors. Individualized plans for women requiring frequent reviews. That's very important, because women would still be at high risk, and we need to continue providing them to these high risk women and not make them feel neglected or unseen. With regards to home monitoring, we can tell them to monitor their blood pressure. Many of them are adept at doing this, using measuring their weight, blood sugars, daily fetal movement count. A very important issue is because they're at home and not really mobile as such. We need to tell them to stay well hydrated and mobile at home, because there is still a looming risk of venous thromboembolism, especially for women in this scenario because they are pregnant. And a very important issue of mental well-being needs to be catered to, because it has been clearly shown that there is an increased risk of perinatal anxiety, depression, and domestic violence. Very importantly, women are not able to come out with their complaints. So whenever when we do their home monitoring or see them, we have to be asking about their mental well-being. And if there are any concerns, we must advise that they need to come and see us physically. Now, antenatal telecontact has been the way forward with teleconferencing and video conferencing, and this can be done as a replacement or in addition to our antenatal visits, especially if the woman does not need any antenatal tests or observations, and we can do it medicine. And one of the most significant changes that has occurred as a result of this COVID-19 pandemic is telecontact. So what are the regulations with telemedicine? Now, for all practical purposes, telemedicine is permitted by MCI. So the same ethical and professional standards should be practiced as per your usual practice. And various forms of communication can be used, your WhatsApp, or if you have a formal telemedicine portal, all that can be used. Ideally, the first consultation should be preferably via a video format. Emergency consultation should be limited to directing the patient or caregiver to the appropriate site. And you should just be giving first aid over the telemedicine and not more than that. Interventions by the doctor could be health education, counseling, or prescription of medications. And whatever prescription should be done, should be all done in a standard format. This is a busy slide, but just want to highlight a few things that medications can be grouped as per the mode of consultation. And list all drugs include that which are available over the counter, such as paracetamol, oral rehydration solutions, and they may be advised by any mode of consultation. However, certain medications like psychotropic drugs, narcotics cannot be prescribed in telemedicine consultations. And when you do telemedicine or teleconsultation, consent is implied when the patient initiates a consultation with a doctor. However, the doctors initiated the consultation, an explicit consent should be taken. You can take this by saying that I consent to avail consultation via telemedicine. At present, we don't need to have any special training to do this telemedicine. In future, we may have a telemedicine program. And the most important issue is that we can charge them, and it could be a chargeable service. So we are not actually doing a free service for them. What about antenatal appointments? Women, whenever it's possible, should be offered a one-stop clinic appointment so that we can club all their investigations and consultations together. Now, in this respect, WHO recommends 8 visits, and RCOG, the Royal College, minimum of 6 face-to-face antenatal contacts in total. Our Indian ICMR recommends minimum 4 visits at 12, 20, 28, and 36. And I think this is mandatory for us to abide by. At least 4 visits should be met unless they meet the self-isolation criteria. And whatever investigations you prescribe here, the results can always be communicated over the phone. But you must keep a watch, as any woman who has missed her appointment or has delayed her appointment for more than 3 weeks should be contacted. And it is important to stress to these women, because there are a lot of them who are afraid or are scared of fear of contracting the virus. They don't want to come to the clinic or hospital. You must tell them that the need for the appointment is greater than the risk of being exposed. And we as healthcare professionals would be obviously taking all necessary precautions. And sonographies obviously can be timed with the antenatal visits. Now, in the rollout phase, we need to make sure that appointments should be scheduled, no sort of walk-in appointments, to avoid waiting time and exposure. The women should be screened ideally with the checklist tool on the telephone if possible. And the patient should make the visit alone or at the most with one attendant. And at entry, they should use a hand sanitizer correctly. A lot of them, just for the sake of it, just wash their hands. They should be told the importance of washing their hands for 20 seconds. They should be given a mask if they're not wearing one. It is our duty to make sure that these women are protected and safe when they are entering our setup. So if they don't have a mask, we should be providing one. And if the checklist was not administered earlier, which is most of the times they would do that, it should be done in the waiting room. And that would be looking for basic questions like whether do you have fever, do you have features of respiratory disease, have you had a travel, especially interstate, in the last 14 days, do you have any household contacts or direct person with the person who meets the above 2 criteria. A lot of them still come having taken a paracetamol at home and then say no, they're fine. So it is important to tell them that they're not doing anybody a favor by doing this. They have to be transparent as to what their symptoms are, and make sure that they will be looked after even if they've had fever, so that they don't go unattended. Do you have any household clothes, which is most important? We should be wearing appropriate PPE while examining the patient. In the consulting room, hello, can you hear me? Yeah. In the consulting room, avoid air conditioning. An exhaust fan should be switched on or the window should be opened. The consulting room should be kept free from clutter and have the minimum amount of furniture necessary. And the patient examination table can have disposable cover, so that as soon as you see one patient, the area is cleaned with a sanitizer, and again, a new cover is put in. This is the government Ministry of Health for Family Welfare, which has shown the PPE, which have made it a bit more simplified as to what we should use in our outpatient department, especially in the triaging area, especially for doctors. All of us are at moderate risk. We should be wearing an N95 mask. We should be wearing gloves. These are basics. Above and top of that, if you want to wear anything more, that's up to you. But these are basics and mandatory. And ideally, no aerosol generating procedure should be done in the OPD. The number of foam mites should be kept to a minimum and frequently sanitized. You should avoid handling all these papers, because a lot of them would come, if their first visit, they would come with a big file with all their reports. Ideally, they should be seen with the patient holding them or by photographs. The consulting room should be cleaned regularly, and at the end of the clinic, the examination table should be disinfected. What about antenatal care for women positive for COVID-19 or in self-isolation? Now, it is important to tell them that these women should have access to women-centered, respectful, skilled care, including whatever care they need. And if they meet the stay-at-home criteria, they should have telemedicine. And if their antenatal appointment is due, you can see them via telemedicine and rebook them after the isolation period ends. If symptomatic, they have to be seen separately in an isolated room if possible. Usually now, pregnant women in our setup, I think most of them would get admitted. But if you need to see them for any reason, you should see them in an isolated room at the beginning or at the end of the clinic to lower the chance of transmission. And all pregnant women suffering or recovering should be provided with counseling. It's so important. The woman comes positive, you tell them stay at home, and nobody gets in touch with them, even a phone call just to tell them, are you fine, what is happening to you. If you have any problems, you can contact us. It is so important to reassure them and make sure that we are there for them at all times in this situation. Now, I'm not going to go into details of this, but a positive woman can stop isolation under the following 3 conditions. And she can have, if she has access, she should at least have 2 negatives tests in a row, 24 hours apart. What about ultrasound? It is a very high risk situation, unfortunately, because though we say we should maintain the physical distance, the proximity is less than 2 meters or even maybe 30 to 50 centimeters. Most of the ultrasound rooms are small and they're enclosed areas, and they often have restricted ventilation. The examination time can be anything between 10 and even 1 hour when if you're scanning twin pregnancies for anatomy scan, that would take almost about 45 to 50 minutes. Sometimes a lot of times we have to do invasive or procedures. Women may be asked to inhale or exhale deeply. A lot of them can't keep their masks on. They feel uncomfortable lying down for that much time. So all these increase the risk of exposure to the patient as well as for us. And so that's why the surfaces of the machine, which are often touched by a lot of people, other practitioners as well, all of them will increase the risk. So with equipment sanitation, the recommendation is that high-level disinfection is not required when you're using the probes on intact skin. Whatever gel is there on the transducer should be wiped off with a soft cloth, and then a low-level disinfectant like 70% alcohol, standard dilute Sidex, Protex wipes, Bacillol. These can be used just to wipe the transducers and the equipment desk board, keyboard, and all of them can be used with an LLD. You don't need high-level disinfection. And ultrasound machines must be used with machine covers and for transducers, especially in COVID designated centers. Normally, we don't need to use them. And in these areas where ultrasound is being used or there is aerosol generating procedures are being performed, then you need to use high level disinfectants. Appointments should be scheduled to avoid waiting time and exposure. As I said, if there is any suspicion, the examination should be deferred, or most of the times if the examination cannot be deferred, it should be scheduled at the end of the list so that you can do terminal disinfection. The Society of Fetal Medicine has come up with these beautiful guidelines as to how you should triage them at the outset, which scans can be done, should have to be done without delay. Some ones can be delayed and some need to be completely avoided. So anyone who come in the emergency as to have any antepartum hemorrhage, suspected ectopic pregnancies, or reduced fetal movements for that matter, we have to do their scans. The ones that can be delayed if they are symptomatic is dating scans or growth scans. But the ones that can be completely avoided are the early ones, 8 to 9 week scans, just to look for viability unless she has any bleeding, or the ultrasounds done in the 3rd trimester for reassurance. So these are the ones you should not ideally miss. The dating should be done at the early morphology scan, where we can combine everything as to the dating, anatomy, risk for preeclampsia, all that can be done in one setup. So we can do that in the 11 to 13 week scan. 2nd trimester scans should not be missed. But if you want to do one routine or growth Doppler, they can be postponed to a 36 weeks assessment where the lady comes to see you, she has the scan and then sees the obstetrician at the same time to decide her further course of action. But of course, decision-making scans like for multiple pregnancies or growth and Dopplers should be considered on priority and individualized. Again, our GCPR guidelines have come up as to how should we be using all these scans in these women. For routine USG, if they are at 11 to 13 week scan, you use the combined test, and if it's not possible, do an NIPT. But if there is suspicion, you reschedule them after 2 weeks. The anatomy scan between 18 to 19 plus 5 weeks. Again, if there is suspicion, you reschedule after the quarantine period is over. And fetal growth scan in the 3rd trimester do not perform unless clinically indicated. But if one scan is required, maybe you can do it at the 36 weeks. For women, modification with suspected, probable, or confirmed, we have to be possibly reschedule the 1st trimester scan. And if it's, if she does need something at that point, we offer an NIPT and then a scan 2 to 3 weeks later. Or if she's hospitalized, again, offer an NIPT. Anatomy scan ideally in 2 to 3 weeks time. So again, if the woman has missed her anatomy scan for any particular reason and a congenital abnormality has been detected, which is major, not compatible with life, you can specifically appeal as a case-to-case basis in the court, and I'm sure that will not get rejected. A fetal growth scan in the 3rd trimester, you reduce the frequency with the first scan 2 to 4 weeks after recovery. But if there is urgency, you need to take adequate precautions and do the scans. The Royal College has come up with these guidelines in 2020, where they have more visits now with their new normal, where they do the booking visit, the dating scans, they see the women at 18 to 20 weeks, they have their routine anatomy, they see the women at 28 weeks, same as before, as we see them. Then they see them at 32 weeks also, at 36 weeks, at 40 weeks, so that they can decide whether this lady needs to go for induction or what would be the course of action further on. The Society of Maternal Fetal Medicine also in the similar lines as to us says that initial OB visit, that is, I would think it's the 1st trimester scan, 28 weeks anatomy scan, and 36 weeks was like us. And then depending on how they need further, a 39-week scan for further management. And maximize support using telemedicine and use all the precautions that we can to reduce contact with symptomatic patients. So we are in the new normal, and that our new normal will be there. So teleconsultation is the way forward. We need to have 4 face-to-face antenatal visits. This is the minimum criteria. Screen and triage on phone or at entry. We need to club the ultrasound with the antenatal visits. Try not to miss the 1st trimester and anatomy scan. And the most important thing at this point is to treat all patients as potential suspects. We should not let our guard down at any point, because you never know which of them would be positive, even for our staff for that matter. And we have to use appropriate PPE for both patients and healthcare workers, because safe pregnancies and childbirth depends on functioning and accessible health system. And that is what we need to provide to all our pregnant women. So COVID-19 is going to be with us for the foreseeable future. So the new normal needs to go beyond clinical care, a more sympathetic, compassionate care for our women who are so anxious and fearful in this pandemic. We need to focus our efforts on this new reality and how we can achieve a sense of normalcy despite all our restrictions, because the disease is still evolving, the scientific discovery is fluid and voluminous, and the patient needs are actually overwhelming. So do not panic, friends, because every pandemic or crisis, it poses an opportunity to learn, improve, and innovate. And that's what we are doing in our pandemic. Thank you so much for your patient hearing.
Thank you, ma'am. Thank you very much for such a wonderful information all about the ANC patients and the COVID-19, and also introducing the new normal with ANC patients and COVID-19 to us. Thank you so much. Now I would like to invite Chairperson Dr. Bhaskar Pal sir for his remarks.
Dr. Swati, we will take the questions at the end, and we will.
Sir, all the questions will be taking towards the after all the 3 sessions.
We'll put the comments also. Let's get on with the comments. Thank you.
Okay, thank you, sir. Thank you very much. Moving.
Swati, you're muted.
Moving on to our next talk by our today's faculty, Dr. Reena Vani ma'am. And to introduce our faculty, I would like to invite Dr. Lata Agrawal, President, Pusat Obstetrics and Gynecological Society.
Thank you, Swati. Very good evening. At the outset, I want to thank NOGS and Vaidehi Marathe Madam for giving us this opportunity, and also congratulate them for the great success of DigiOGAN. I am privileged and honored to introduce Dr. Reena Wani, who is a great teacher and academician. Madam is MD, FRCOG, FICOG, DNBE, FCPS, DFP, DGO. She is Professor and Unit Head, HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. She was Chairperson FOXI Perinatology Committee from 2015 to 2017. She is President Mumbai Breastfeeding Promotion Committee 2019-20. She is Core Committee FOXI Violence Against Women Cell 2015-21. She is editor, co-editor of 14 books and author of 2 textbooks. She has 50 plus chapters in FOXI and other books and over 75 publications in journals. She has 2 gold medals, 5 distinctions, 24 prizes and awards to her credit. She is convener, invited speaker, faculty for international, national, state and other programs and community public health talks. She is postgraduate and undergraduate teacher for DNB, DGO and MBBS and she is a referee for MRCOG also. She is a WHO certified trainer for adolescent reproductive and sexual health, DIP, SI, CCICP, HDP and FOXI trainer. Awarded MOGS SN Pandit Award 2017, MOGS Ganatra Trust Prize for contribution to social issues, Dr. R.D. Pandit Prize twice and Dr. Duru Shah Best Committee Member Prize twice from MOGS. She has been Mumbai's top docs by Internovation India Today 2010-2011. We are very much privileged, ma'am, to have you. Over to you, ma'am.
Thank you very much. And in my journey in academics, Vidya no Rugvimuktaye, which means through knowledge we shall conquer disease, has been the motto of Nair Hospital, where Dr. Bhaskar Pal and I were colleagues together. And throughout, we as gynecologists have been giving priority to maternal health, to the Mata, the Devi, the Janani, who is looking after the child. But right now, as Seetha beautifully put it, with the new normal, there is pandemonium in this pandemic and everything has changed. Which is why I'm really glad that Vaidehi has invited me to speak on protocols and practical advice for the mother-baby dyad. In fact, Seetha has made my life much easier by giving the details with the FOXI GCPR guidelines for antenatal care. So I might rush through a few of my slides, but I will focus on what are the practical management and what has actually been done. I bring you greetings from Mumbai. All of us are talking about healthcare, what is ideal. Even in the GCPR guidelines, there are certain situations mentioned. But how, even in the city of Mumbai, behind the iconic Taj Mahal Hotel, you have the urban slums of Kulaba. We have a mismatch in what is available at different places. So what do we need to do in healthcare? We have to make best of what is available. So in my talk, I will be focusing on certain areas that particularly when should pregnant women be tested? Does mother and child transmission occur during delivery time? Issues like cord clamping, skin to skin contact, testing of the mother, testing of the baby, where to keep the mother, what about breast milk, and what should be done. So Seetha has already mentioned that in ANC OPD, there are certain things to be followed. But specifically, I would like to say there are 2 areas we have to talk about. One is screening and triage. And what are the standard precautions that need to be taken? That is something which is common, but that is something which is different in our current pandemic scenario, where of course it is hand and respiratory hygiene, appropriate PPE, patient placement, environmental cleaning and surface disinfection, and again, biomedical waste management. There are hordes and hordes of red bags and yellow bags which have to be disposed, and there are issues about, especially for private nursing homes and smaller setups, how do we dispose all the waste that is generated in this? Now, Seetha has given the details about all this. So the bottom line is that there doesn't seem to be any specific effect. Only thing certain studies have suggested, preterm labor does seem to have increased in the COVID situation. Now, as healthcare workers in our OPDs, one thing I would like to emphasize, notification to the appropriate authority is very important. If you fail to inform the appropriate authority, It is actually a failure of the healthcare system, and we need to maintain a registry, whether you are in public health or in private practice. It's not just enough to have a fancy PPE. If it is not used properly, it fails to serve its purpose. And that is what we need to emphasize by training our staff. In fact, when the COVID pandemic started, we had a lot of our own nurses, healthcare workers becoming positive despite having PPEs in the hospital because of probably lack of awareness. Hence, we kept having in-house training programs to let everyone know how it should be used and removed carefully. Particularly, doffing, that is removal of the PPE, is the time where if it is not done properly, you can get infected. And ideally, there should be separate areas in your facility for negative patients, for suspected patients who are awaiting test report, and third area for positive patients. That is how you organize your facility, but that is a separate talk in itself. And of course, social distancing must continue. Now, medical history is what already has been discussed by Seetha, so I won't talk about it again. But here, what I would like you to remember, it is not just the patient who you are triaging. You also need to triage the visitors and healthcare worker professionals and hospital staff who sometimes are exposed to a patient whose report comes later as COVID positive. And then there is confusion about what needs to be done. And in fact, in the last part of my talk, I will be talking about different types of protection which the healthcare worker needs to take for themselves when dealing with COVID positive mother and baby. So this is just to show that in the normal OPD, we still have a very crowded OPD. And in fact, when the COVID pandemic started in my own hospital, all the other departments had a lighter OPD. Ours increased because the surrounding smaller nursing homes and maternity homes were not seeing patients. It's important to screen patients at first contact, and the simple handheld non-contact thermometer should be given to the security guard at the entrance of your facility or to somebody in your nursing home who's sitting outside. Maintain the 1 meter distance. Now, how do you maintain that? By having simple markings on the floor, which will help you, or in the chairs. One chair should have a cross. That means don't sit here and these next. So people have one gap between the chairs at least. What is shown at the bottom of the screen is what is ideal, a lovely glass or plastic screen. It is not possible in all areas. And mask, a lot of studies have suggested addition of the face mask and eye protection with clear goggles if you don't have glasses is important. Again, Seetha talked about teleconferencing and this, but especially in public healthcare, it is very difficult to do. And sometimes you have walk-in patients, so you cannot always maintain that. This is a picture of the chart, which can be just printed or downloaded from the WHO website with the screening form. Now, this screening form should not only be given to the patient who has come to your antenatal OPD the first time in addition to your regular ANC form, but ideally, if there is a doubt, one relative, that also we talked about restrict number of relatives, to that relative who is accompanying if you feel. Now, basically, antenatal patients who have come to you can be categorized into 3 groups. One, who is just your regular antenatal patient, who does not have any positive history or any specific comorbidity, but another group who has comorbidities like pregnancy-induced hypertension, cardiac disease, deranged glucose tolerance or over diabetes in pregnancy, asthma, and other chronic diseases, hematological or immunosuppressed status. And the third group is somebody who has come with symptoms like breathlessness, which is more than what normal pregnant woman also sounds a little breathless, but with a respiratory rate which is above 30 is definitely significant, who has come with a fever or with cough or with lung changes which have been picked up by imaging to involve 50% or more of the lungs. So these are the 3 groups. Obviously, if the symptomatic or third group, she would be seen first by the medicine people or seen by you in conjunction with the medicine people if she is in labor. The second group is where you have to be vigilant, but the first group usually does very well. Now, who should you test? Definitely, the symptomatic group needs to be tested, but even an asymptomatic regular pregnant woman who has filled the form, who has the history of contact. Now here I have to share that unfortunately nowadays, sometimes patients hide the history of contact. I will be presenting the data of what we have done in our hospital. And I'm sorry to say, one of the maternal deaths which happened, the patient had hidden the history of contact with her mother-in-law who was COVID positive because she wanted to get admitted in the hospital. But fortunately, we test everyone. So we had tested her also, and the report came later. Asymptomatic antenatal women in clusters or containment areas, this applies more to places like Mumbai, where we are having a lot of hotspots, and my hospital has almost everybody coming from clusters. So we are testing each and every person who walks in. Those who are in labor, so those who are about to deliver in the next 5 days, it has been recommended. Now, Seetha has already talked about the details of antenatal visits, so I'm not going to repeat this. In the receiving area also, it has been mentioned, but I would like to add, people have given things from A to Z. They have given homeopathy, hydroxychloroquine, anti-parasitic drugs like ivermectin, micronutrients. There's a lot of this, thought on what should be given. Please remember, for asymptomatic pregnant women, high protein diet, yes, micronutrients, particularly vitamin D and vitamin C, in larger proportions than what we would have given in the normal situation are important, and so is zinc. Hydroxychloroquine, there is a lot of controversy, but I would like to share here that hydroxychloroquine has been used by us for my entire department, and we are very happy with the results. We have not had any adverse events. Of course, it was with patients, it was not just for doctors, it was also for nurses, and everyone took hydroxychloroquine, which was supplied by the administration, and we feel it has probably protected. And there was a study going on of which the results are not yet out. Doxycycline is used in non-pregnant women, but azithromycin is an antibiotic which can be used if your patient is having mild or moderate symptoms as supportive care, and of course paracetamol and other things as required. In labor, Dr. Nozer will be talking about it in detail, but I would like to just emphasize that maternal observations, which we normally do, we have to focus on respiratory rate and oxygen saturation. The humble little pulse oximeter. It is now, in fact, I would like to say Rotary Club, even our Mumbai Society has donated to our hospital for the Obs and Gynae department, and Rotary Club donated 100 pulse ox for entire Cooper Hospital, which is very useful because that helps us to monitor patients in different areas. I'd like to speak a little bit about the pulmonary system. These are pictures showing typical pulmonary edema, pleural effusion, and ARDS picture. We don't often do imaging in pregnancy, but here you must remember, friends, that when in doubt, it is better to do imaging with consent and abdominal shield rather than not do imaging. And there is a role, if you have an adequately trained person, to do lung ultrasound. HRCT can also be considered if there is a doubt, but it is not used for screening pregnant patients to categorize them, but in patients who are symptomatic or in whom you are doubting lung disease. So we need to watch for symptoms and be liberal with imaging. And here we have to have a multidisciplinary approach and also get the medical opinion. This is also important medico-legally, and these are high-risk patients. Maternal mortality is a serious issue, and every maternal death is audited. We have a district quality assurance committee review, and we don't want, and we want each and every mother to survive. Of course, that's what each of us want. So remember the word happy hypoxia. Patients may seem comfortable, but sudden drop in oxygen saturations have been known to occur, and our aim is to keep the saturation of oxygen above 94. It is not lower than that. And when it comes to the low 90s, that is a sign, and then suddenly the patient may deteriorate. And then you need to do further testing like arterial blood gas and other things. So intrapartum, one important message I would like to say that cesarean section is for obstetric indications only, and COVID-19 does not affect the mode of delivery, and epidural is a choice for analgesia, and if it is in place, it is useful if you need to suddenly do an emergency cesarean section. But sometimes the woman is hypoxic and exhausted, so a judiciously applied forceps or vacuum will be useful. I'm going to focus now on the postpartum care. Now here, asymptomatic positive women can be roomed in, but it's important to isolate them from others. Ideally in your facility, you should have 3 areas. One is those who are definitely negative should be in a separate area. Those who are awaiting the test result or are suspect should be in one area, and the third area should be for COVID positive. Now you will tell me it's not possible for all of us to do this. In my own hospital, we did not have place. And in fact, we kept talking to our administration that we need to do it. And finally, we carved out a space from what was already available because it's difficult to do that. And we made one ward COVID positive, gynec and obs isolation area, because we did not want to mix our asymptomatic postnatal or antenatal pregnant women with really sick patients from medicine in which male and female were mixed, because that's where they were going. And that has really benefited it because it made our lives also easier to monitor them. And we don't really need to do anything specific. If the patient is really sick, yes, we do send them to the medical ward or the ICU as required. And this is also MCGM guidance, that's the Municipal Corporation of Greater Mumbai, has given guidelines which are updated regularly. And they do recommend rooming in with consent of the patient. Now, it is sometimes not possible for having enough staff to look after, especially when you have large numbers. But what we do is we have one designated person who wears the PPE and is looking after the COVID positives. But in the other areas also, I will talk about what PPE needs to be used where. But in other areas also, we have to use precautions because some persons may be in the window period or the results may not have come in. And also remember, the nasopharyngeal swab by RT-PCR, 1/3 of the cases may be false negative, which is that if the swab is positive, she's definitely positive. But if the swab is negative, there is a possibility that the swab may not have been taken correctly or patient may be in the window or the incubation period. What happens is that if you don't have enough staff to look after everybody, you have to find one designated relative who is told that you should be the only person. We don't want more and more people. You should be aware that you will be exposed. And in fact, our guidelines also suggest offering hydroxychloroquine prophylaxis to that relative who is along with the patient. And that one can help the mother for breastfeeding or handling the baby at other times. Again, doing masks and practicing hand hygiene for everything. So this was also a consensus guideline for neonatology, which was made by, which was released at the end of May in our own MCGM, and of course ICMR guidelines. Now I'll just share with you a few studies. These were initial studies which talked about intrauterine and vertical transmission. There is currently no evidence. Another large meta-analysis of 405 babies born of COVID positive mothers with RT-PCR done in almost 80% of them, only 9 babies were positive and only 1 baby was symptomatic. Again, bottom line is there is very limited evidence of vertical transmission. Now, what about breast milk? This was a nice study which actually did the antigen testing by RT-PCR in the breast milk samples and tissue culture. And again, bottom line is that breast milk is not a source of infection for the infant. Now, these are just a summary of few guidelines about management of neonates, with what swab to be sent, whether kangaroo care can be done or not, and what should be the discharge policy. Now, if you know that the mother is COVID positive, it has been suggested that the first swab should be done after birth or at 24 to 48 hours to know about the baby. If the mother's COVID status is unknown, wait for the COVID report. In fact, most people recommend doing the swab of the baby at 48 hours is ideal because that gives you enough time and the pickup rate is better. Outborn neonates actually is something which a lot of NICUs don't take now. Now, if the first swab was negative, you don't need to repeat the swab in most cases. And what is the swab? And if the first swab was positive, if the baby is symptomatic, you need to repeat when, if otherwise, again, most cases, you don't need to repeat the swabs. This is actually a picture from the newspaper when Sion Hospital, which is a non-COVID designated center, crossed 100 deliveries. That time we had reached about 80. But I would like to say across Mumbai, a lot of people are doing work. Although Nair Hospital is what we call as a dedicated COVID care center where they do not take non-COVID pregnant patients or deliveries. Unfortunately, certain hospitals which are COVID care centers do not take laboring patients at all. I don't know how it is across the Vidarbha societies, but in Mumbai, there's a bit of discrimination because certain COVID care facilities say we cannot manage, we will not take pregnant. So that's why it's a problem. So you have to have protocols in place, and in your own city or your own town, you need to know which are the COVID care facilities which will deliver when you have a COVID positive, or create a separate COVID delivery area in your own hospital if you feel you can manage. Now this picture in the center is of that brown door. This is actually one of the areas in my own gynec ward, because that was the holding area, because our staff was removing the PPEs in the corridor, which did not make sense, which would again be a source of infection. So again, we found that, okay, this was a extra bathroom which was being used by the sisters and staff. We found an area outside that. We had to talk to them and say that, please, this is for your benefit. Let us make this a doffing area. So you need to create donning and doffing areas. Donning is not such a problem, but doffing or removal of the PPE has to be done in a specific area in a proper manner. Now, this is very important data. Now, this is to show you the total across Sion, Nair, KEM, Cooper, and Wadia, which are the public hospitals. You can see the second column is showing how many COVID positive mothers. This is up to July, we have had 1,413, of which 221 deliveries were in my hospital. Now here I have calculated in the column of Cooper to show, in the row of Cooper, to show that out of almost 1,500 total deliveries, 14.8, that is 15% women were COVID positive, and most of these were asymptomatic patients who were picked up by routine screening. Hence, I am absolutely in favor of routine screening. The policies keep changing. Fortunately, in our hospital, it is done free of cost, and we have our own in-house screening, which developed over a period of time. Initially, it was being sent outside, then the need was appreciated by the administration. Now, within your own setup, you have to decide where you are going to send the swab test. We trained our own gynec residents of how to take the swab, because initially there was only one person in the fever OPD who was taking it. So there was a lot of waiting period. So these are all things you learn along the way and find what works to make your life easier and your patient's life easier, and to have your results coming in more systematically. Another important point in our Cooper data, you can see only 0.9% of our babies have been tested positive, although we are doing exclusive breastfeeding and rooming in, unless the patient refuses consent or she is too sick to handle the baby and needs to go to the medical ward or the ICU. So separation of mother and baby has not happened. And I would like you to also look at the row of Nair, which is a designated COVID care center. Obviously, they only do COVID positive deliveries. So all the mothers are COVID positive. All the babies were tested. Again, there it is, you can find that the number of babies who is positive is relatively very small. And they have also practiced bedding in and exclusive breastfeeding for their babies. So neonatal care, to summarize, you must room in, but isolate them from, if you're awaiting the results from suspected or infected cases, if they are negative. And if the isolation is not possible, wait till the reports are available. And of course, a symptomatic baby, even if the report is not awaited, you have to keep in isolation or in a COVID positive NICU. No specific treatment has been, like I said, for the mothers. Even for the neonate, there is no specific treatment recommended or any specific investigation. And please remember, immunization, the birth dose of BCG, oral polio vaccine, and hepatitis B has to be given irrespective of the COVID status. So don't worry about it. In your private practice also, that should be followed. And the feeding policy, I have already emphasized, breastfeeding with respiratory and hand hygiene. One important thing, maternal love, umad के आ रहा है, बाळाला आपण पप्पी देणार, असं पकडणार, ते सगळं बंद करा. We have to talk to the mothers and the relatives that please restrain your maternal instincts right now when you're COVID positive. Only when you're feeding, keep the baby with you, and after that, keep the baby in the cradle and away from you. If the mother is seriously ill, that designated relative can help with a breast pump or hand expression of breast milk if it is possible, if the mother is not in ICU, or if you have the option, pasteurized donor human milk, or then suitable top milk options. And kangaroo mother care has been, can be practiced if required with strict respiratory and hand hygiene. Now, when should you send them home? COVID positive mother can be sent home if she is symptom free for the last 3 days on day 10 from the time the symptoms arose. I'm not saying from the time of delivery. So it depends on patient to patient. If the swab was done for an asymptomatic patient, ideally you should wait till the 10th day, because if the woman is going to become symptomatic, it usually happens between the 7th and 10th day, including things like cytokine storm and other things. So we keep them under observation, and this is the policy we are following in our own institute. And do not worry if you cannot keep doing swabs. Again, availability of swab test is a problem. And the guidelines, including the ones from our MCGM and others, say that there is no need for repeating the swab before discharging the mother. And of course, follow up, and what was beautifully mentioned by Seetha, having phone numbers and telephonic contact and looking after the psychological health and counseling. For example, the relatives once were getting agitated and having a fight with the security guard outside the ward. What we did was, me and 2 of my team went and actually just gave a 10-minute talk to them about what is the importance of not allowing the relatives to go in. Otherwise, they will stay outside. So talking to the, not just to the patient, but the relatives on a regular basis is also very important. About discharging the baby, asymptomatic baby can be discharged irrespective of the COVID status with the mother. Mild to moderately symptomatic baby only after the symptoms resolve for at least 3 days. And of course, symptomatic babies based on the clinical picture, and we would repeat the test before discharge. Now, what all I have spoken is summarized beautifully in this WHO guidance, which is the scientific brief. So I am not going to repeat it, but 2-3 important points. They have recommended delayed cord clamping more than 1 minute after birth, and facilitation of early skin-to-skin contact with infection prevention control measures and rooming in. Psychological support, respectful maternity care, do not separate mothers and babies, and identify another competent caregiver if the mother is unable to care for the infant. And we have already talked about options if she cannot breastfeed, and precautions using breast milk substitute, and assistance for relactation once she is better. These couple of these slides are important because I'm comparing the guidance given by WHO, Center for Disease Control, American Academy of Pediatrics, and RCOG. You can see that most of them have recommended skin-to-skin contact, delayed cord clamping, that is after a minute, and rooming in. The CDC, the Americans want, they have a lot of place, so separate room, have an isolate, distance more than 6 feet. This is not practicable. And direct feeding also is recommended by most of these bodies. And these are our Indian guidelines: ICMR, NIRRH, FOXI, NNF, GCPR guidelines, infant and young child feeding, and breastfeeding promotion network of India guidelines, which are again compared here, all of which are recommending that rooming in with physical barrier if possible, and if you can do 6 feet distance, great, but with infection promotion control. The express breast milk is, this has also been discussed. And this is a flow chart which you can download and print out and keep it in your labor room. So it makes your life easier so that you know what is to be done. It is a flow chart with whatever I have said. It is a WHO, and it is available from our Ministry of Health and Family Welfare website. You just need to download it and print it out. So friends, what do we need to do? Sorry, I'll just move the window away. It's covering the slide. Yeah. I'm almost at the end of the talk. We are looking after women from womb to tomb. We are not just the specialists, we also give them primary health care. So in this reproductive health, in the COVID crisis pandemic, we have to be responsible, and it is we first three who will change and manage. Now, prevention is better than cure. Now, for the healthcare workers, what do we need to do? There are different types of PPE available, and what should you be having for each point? Now, at the triage point, like where you're having the entry point of the screening personnel are there, your security guard, your person writing history, the intern, or whoever, just a surgical mask, hand hygiene, and gloves is adequate. for collecting respiratory specimen. For example, my resident only collects the swab at the point of entry because of the problems in getting the specimen collected for nasopharyngeal swab from the fever OPD. What we make them do is have the surgical mask and a face shield. Of course, the gown type of PPE is adequate with gloves. Now, when you're looking for a suspected or confirmed case where there is no aerosol generating procedure, similar to what I have said before, has to be done with proper infection prevention measures. Where you are thinking of aerosol generating procedures, yes, it is better to have a non-permeable PPE. That is also important, that the quality of the gown, it should be, there is a 90 GSM. The GSM is the quality of the PPE. You get 50, 60, 70, 90 GSM PPEs. So we prefer the one which is 90 GSM. And if we get little longer gloves or gloves which will properly cover is also important. Transporting a case, for example, from you have to transport the patient for ultrasound. Patient is quite sick, you need to take her to another, or you have to transfer her to another hospital. Goggles, face shield, surgical mask, gown, and gloves. Even the people who are cleaning are very important because they are the ones who are removing the biomedical waste and other things. And this is something we have to look at. And they should actually have foot covers or boots and heavy duty gloves. You can even have washable, reusable aprons for them. And we have talked about where the patient should be kept, ideally single occupancy room or a dedicated isolation ward, and give them face masks when they are being transported if they don't have, and even the relative or attendant should be given at least a triple layer surgical mask. Now, what should be done is for safety is decontaminate your hands, don the PPE, inform the destination staff. If you're transferring or sending, for example, even for ultrasound, or you're transferring from the hospital, phone, make sure everything is in place and then do it. And ideally, you should have a single line or an area how you're taking the patient out. And if you're transferring, we have, again, there was shortage of ambulances. So certain school buses have been converted into COVID ambulances, which are then labeled as COVID ambulances and which are used for that. So the key messages: notification, registry, preparing your facility, properly using PPE, separate areas for donning, doffing, knowing the protocol in your own institute, and protecting yourself. Teamwork. Together, everyone achieves more. We all have to work together, and from the cleaner up to the head of department, everyone is important and everyone has to be together for the COVID pandemic. There is some evidence of vertical transmission, but most babies are largely asymptomatic, so it is a very small percentage. Delayed cord clamping, skin-to-skin contact, kangaroo mother care with proper infection prevention control, yes. Very limited evidence of breast milk transmission, so we do allow breastfeeding, rooming in, direct breastfeeding. Do not separate mother and baby unless very sick, and repeated emphasis, talk to them and educate them. These are certain references which you can refer to for further details of what all I have spoken about today. And at the end, I would like to thank all of you for a patient hearing, Nagpur Society, and my COVID warrior team who have been working tirelessly in this pandemic to make sure that our patients are safe. Some of them have tested positive, have been isolated, and have come back to work. So, and MOGS has actually donated certain items to our hospital and other public hospitals to help us to work. And I thank you all, friends, for being here with me.
Rajyasree?
Yeah, Vaidehi.
Yes, sir. Yes, Dr. Bhaskar.
Noser is in a bit of a hurry, so let's start with Noser.
Yeah, let's start right away. Yeah. Ma'am, can you just please stop sharing the screen?
Sorry.
Welcome, Dr. Noser, sir. You spared some time out of your hectic schedules. Thank you so much. I just request, give us 2 minutes. I request Dr. Shruti Sune to just introduce you, although you don't need any introduction, we know that. Shruti, over to you. A quick introduction.
Yes,
Shruti?
Yes, ma'am, sure. Dr. Noser Xavier, sir. Welcome, sir. Sir is a past Secretary General and past MTP Chairperson of FOXI, past President of Mumbai OBGY Society, working at Breach Candy Hospital, Hinduja Khar and Holy Family Hospital. a scientific chairperson of 22nd PIGO Congress, Rio de Janeiro, delivered 16 orations and over 500 presentations, edited many books, published many papers and chapters. There is FRCOG, AOFOG Young Gynecologist Award, many Foxy Awards like Dr. Hansotia Best Committee and Dr. Datta Best Publication Award. Many awards at Mumbai Obstetric Society like Dr. Bhatia Young Scientist Award, Dr. Ganatra Community Service, Dr. Desai Excellence, Mr. and Mrs. Pandit Women's Empowerment Award. Sir is member of Technical Advisory Group, WHOC Region, a member of Governing Board, Guttmacher Institute and C3. Sir is a co-chairperson of Medical Advisory Panel, FPA India. We welcome you, sir.
Thank you so much.
Okay,
thank you, Vaidehi, Bhaskar. It's a great privilege to be speaking after Seetha and Reena. Excellent talks. There might be a little bit of repetition, but my focus is going to be a little different. And my focus is primarily going to be on practicing under the COVID cloud and delivering patients. Can you see my screen?
No, sir.
I have shared the screen.
Have you shared the screen, sir?
Yes, I have.
So can you just stop share and then reshare because you cannot see the screen yet.
Have you allowed him?
Yeah.
Yes, he is the co-host.
But I'm clicking share screen, but it doesn't seem to be coming on.
Thus, as Swati suggested, can we just stop share once and then reshare again?
No, but sharing, I can stop share. I'm clicking share screen and nothing's happening. So
any other windows that can be minimized, maybe? Any other windows are open, maybe you can minimize those and just keep the active window open.
Should I make Dr. Nozer sir the host? Should I try that?
Ma'am, sir, can you mail us your PPT so that we can share? I'll put the email ID here.
I've got
That will take some time, no, Swati?
It will take time.
Could you just put me as the host for this?
No, sir has a second gravida in labor at 7 centimeters, so he's
very
naturally tense.
I dare not get.
I'll make you the Swati. But how will you make me the co-host? So I'm making you the host now. You are the host now, sir.
Yeah.
Swati, can you assign me the co-host or you can't do it?
No, ma'am, I won't be able to.
Then you will need to make me the co-host then in that case. Just take a second. You're the host now, so you should be able to share.
I'm going on share screen and nothing seems to be happening. I'm getting a blank screen after that.
Have you, your presentation is open?
My presentation is open. I've minimized it.
No, don't minimize it. Open it fully and put it in the back window. Open it and put it in the back window. Don't minimize it.
Now, Bhaskar, not coming. Okay. I have it in the back window now.
So there's a suggestion from the audience that you can shut down the PC. I mean, restart the PC once again, the laptop once again.
Now,
Yeah, it's coming, sir.
Yes,
Yeah, it's there.
Yes. Yeah.
I can see that, sir.
Yeah. I guess because it was minimized, that was the problem.
all right. These are strange times, and we have new normals. So we live in a very interesting time. But this is not the first pandemic that we are really dealing with. In the last 20 years, this is actually the third corona pandemic that the world is dealing with, after SARS in 2003 and MERS in 2012. But this has a different level of infection, and let's face it, we've had 780,000 people who've already lost their lives. I saw the statistics which said that 247 lives per hour at almost 15, a life every 15 seconds, and no region of the world is spared. Arundhati Roy wrote, historically, pandemics have forced humans to break with the past and imagine their world anew. This has happened from the medieval ages. This one is no different. It is a portal, a gateway between one world and the next. And today I speak about the new normal as far as this most essential service of obstetrics is concerned. I'm going to focus on deliveries under the COVID cloud. The previous two speakers have very efficiently done the prenatal care. Reena has talked about managing COVID positive patients. I'm going to talk to you as a fellow private practitioner who has to deal with this in our day-to-day practice of our own patients, and many of whom will be infected. Well, the first thing we are dealing with is not just a pandemic, which is a medical problem, but it's also a very, very emotional mental health problem. And there was this update by the National Institute for Mental Health, which said that there is something they call as the worried well. These are the healthy people with less severe problems, but they have concerns about their health. And the kind of worried well patients we are dealing with because of the COVID pandemic is something that we've never really come across before. Their recommendations are don't turn them away, don't dismiss the problem, make them feel understood, provide them with authentic clinical information and reassurance support. And I believe that this has been the role of the obstetrician. You know, everything else would come to a standstill, but every month that India was under a lockdown, we were delivering 2 million women, because we do about 26 or 27 million deliveries a year as obstetricians or caregivers for women. And we had a role to play starting pre-conception. A lot of women were worried about conceiving at this time, throughout the prenatal period, intranatal period, and the postnatal period. Now, there was this interesting study called the CARE study where they looked at, they sent out this questionnaire. They had 1,400 responses. And interestingly, they found that 1/5 of respondents were not comfortable just talking about the COVID-related studies. They just wanted to keep them kind of turn a blind eye to them. But 40% actually said that their providers had not actually discussed the effect of the pandemic on labor and birth. And about 25% of these were actually in the third trimester. Okay, this tells you how important it is for us to always, but more so now, engage with our patients. 45% said that in some way their birth plans had to change because of the COVID pandemic. Seetha spoke to us about prenatal care, and I shall speak about prenatal care when it comes to, I shall speak about prenatal care as it comes to close to delivery. And in this case, we see patients periodically. Obviously, we manage minor ailments remotely. Growth scan in the third trimester. Okay, Bhaskar, I'm really, really sorry. I'm going to have to cut this short. I'll try and get back in some time if possible after the question and answers. But I really am being called to hospital now. I'm so sorry. Hello? Bhaskar? Vaidhi?
Yes, sir, here.
I'm really sorry. This is a very dear patient.
Sure, sir, no problem. Surely, sir, no problem.
I'm sorry. I'll
So
try.
before leaving, can you just make Vaidhi ma'am a host again?
Yeah.
If you can just make Vaidhi ma'am co-host again, that will be a great help.
How do I do that?
So you go to the participants.
Okay.
Against Vaidhi ma'am's name.
Got it.
There are 3 dots.
It's done.
Make co-host.
Thank you.
Yes, sir. Thank you so much, sir.
I'll go to hospital and see if I can try.
Surely.
I'm so sorry.
Thank you.
Surely.
Thank you so much, sir. Please go ahead. No problem. We understand. Hope to see you soon after the question and answers. Maybe by that time your patient would have delivered. I think sir has left. Reena ma'am, if you can take up a part of his talk, that what he wanted to speak was on scheduling deliveries in the under the COVID cloud. So maybe you can give certain
If you
tips.
have the slides, I can go through them. There is no problem because I am dealing with the same thing. So in fact, I had cut out that information from my talk. So if you have,
So you
the
can
slides,
share. I don't think so because sir has already left the meet.
So let me just in a few things, emphasize. I had rushed through a couple of my slides, but I will just summarize what was important. Now, there are 2 or 3 important points. Is that can you delay the delivery when a patient has tested positive in the antenatal period, but she is not in labor? For example, we have patients who have come into our hospital with gestational, with deranged sugar or something. We did her COVID test, or somebody who came with a bleeding episode as placenta previa at 28 weeks, and we do the COVID test. Now she has tested positive, she's in the ward. What do we do with her? We shift her to our isolation, gynec on and off isolation ward. But then we have to decide: are we going to keep her from 28 weeks to 40 weeks, or can we send her home? Because again, there also we have limited number of beds. There are these logistic issues. So the delivery plan will be affected by what was the condition for which she has been admitted and why your antenatal patient tested positive. For example, a person with gestational diabetes mellitus who was admitted and turned out to be COVID positive, we did our best to get her sugars under control and then sent her home with a home management plan because there was no indication for urgent delivery. And the important thing is that after 2 weeks, mostly she will turn negative. When she comes for delivery or is 5 days from delivery again, we would repeat her COVID test. That would be helpful. To give you another good example, again from our practical cases, we had a patient who got an ultrasound done, unfortunately, at 21 or 22 weeks and found there was anencephaly. Now, she had already crossed the legal limit for termination of pregnancy. Because of availability of ultrasound and other issues, it had become late. Patient came to us and we got, again, as routine, she was asymptomatic. We did COVID test at entry point. We were doing her workup, whatever, and this. And we found that her COVID test was positive. First of all, there was the dilemma, moral and ethical dilemma of anencephaly. Do we make her way to term or do we put it as induction of labor and other things? Now with the COVID test, what do we do? So to be honest, this is not an urgent indication for delivery. We have actually sent her home with counseling and told her, because she was asymptomatic positive, after that standard, whatever is the discharge policy in our hospital, keep her under observation from the time of testing up to the 10th day. She is okay. We have delayed it. And then told her she will be a patient who we will retest and then we will consider about them. Now, this patient was managed in this manner. But there was a placenta previa who was near term, who had to be kept until she needed delivery. But another example I will give you, there was a patient who had come in 2nd trimester with a clot on ultrasound under the placenta. She was a G2A1 who had one previous abortion. It was a wanted and a precious pregnancy. There was a significant retroplacental clot, but she was tested COVID positive. Now, what to do with this patient? Again, for her pregnancy sake and the fact that she wanted, and there was oligohydramnios on the scan. for her sake, we tried to pull through the pregnancy further with the routine masala, whatever we give. But unfortunately, she kept getting uterine contractions and this, and there was no choice. So we had to induce the abortion. Now, again, if you have a designated, we have only a single bed in a designated area for delivery, whereas the rest of the labor room is common. And again, we created this area because, again, being a public hospital, you have restrictions of space. We had to find one suitable room which had hand washing and other facilities, separate entry, where we could deliver. And we got one of the labor tables from the other area and shifted it in. So again, this is how you prepare your facility. Don't say, I don't have it. Whatever you have, create proper place from what is available resources, and don't feel माझ्याकडे काही नाहीये. तुमच्याकडे सगळं असू शकतं, जे आहे ते व्यवस्थित वापरा आणि ते मिळेल. तर मी इनफॅक्ट आमच्या रेसिडेंट्सला पण हे ट्रेनिंग देते की तुम्ही हे म्हणू नका मी म्युनिसिपल कॉर्पोरेशन मध्ये आहे, मी पब्लिक हॉस्पिटल मध्ये आहे, माझ्याकडे काही नाहीये. तुमच्याकडे सगळं आहे, जे आहे ते व्यवस्थित वापरा. So again, but having only a single labor table becomes a problem. Now, if you're doing an induction, so in what again another solution we found is, if there is induction of labor or abortion, when we have a single labor table for these patients, we do it in the ward. And we anyway have one person with PPE sitting in that ward. So that person only will monitor this case also. And when the patient is ready to deliver, we shift. Now, certain people think, "Ata COVID positive delivery zali, we have to shut the entire thing." No, just a routine within 2 hours, that table can be prepared again. And you have to have one more backup area. So supposing somebody is delivered and there's a need for urgent delivery, we have identified another separate OT, which was the trauma OT minor. So we have, with administrative permission, that in dire emergency, when our area is blocked for cleaning or there is already a patient, a second area has to be identified. Now this, each facility has to decide and find out what you have and create the place and the facilities based on what is available. So this is something which, and another important point, which I actually, because of my talk being focused on certain area, you should have a weekly review meeting. Now, if it is not possible to have review meeting with your team, you can have a WhatsApp or a Zoom meeting with at least a few key people. Now, if you have 3 units, for example, we have 3 units in our department. So we have a meeting of 3 units and we have identified one senior person in each unit who is responsible. If you have 7 people, everybody is doing everything, but then finally, if there's something goes wrong, nobody is doing anything. So you have to have a hierarchy in place with one person taking responsibility and review, especially in these COVID times and situations, because things keep changing. Again, guidelines keep evolving. For example, discharge policy guidelines, initially because there was no separate isolation ward or this for post-delivery patients, we were told discharge them on the 3rd or 4th day. If you have no place, don't have crowding. Otherwise, we were actually having, the ward was full and overflowing. But then the discharge policy came clearly that keep them under observation till the 10th day or shift them to level 2 facility. Now, what is this level 2 facility? It is a, for example, we have a NESCO ground at Goregaon, or we have these, the public work department had a building which was converted to a level 2 facility, which is not a hospital, does not have doctors fully equipped round the clock, but where stable, relatively asymptomatic or very mild symptom patients can be shifted. So that is a kind of flow chart which has to be in place, and this should be put up in your labor room with the phone number of the places, because otherwise there is chaos. Because especially you have people working in shifts, the duty rota keeps changing. So sometimes it happens that one person knows, but the other person may not know. So written protocol in place is also very important. And if you have your weekly review meetings, you find out if something went wrong in a particular area. For example, once we had a mob of relatives coming and creating hangama that we want to take our patient home because the patient's COVID report came as positive. And they said, no, it is because we have come to the hospital. And we had a counseling talk with the relative and emphasized to them that we have tested you at entry. The COVID report has come positive after that, after 2 days, because there's a turnaround time of that much. But the swab was taken when you entered. There is no need for you to get agitated. Now, this is a situation which could have become violence against doctors. So we took the security guard, They were arguing with the junior resident who was saying, we are shifting you to the isolation ward. And they did not want to go. They said, we are going home. So here we had to have a senior person, a security guard stepping in, discussing and again counseling them that, look, this is the situation and we will be able to help you. And if you have your patient here, and then finally they calm down and they agreed to shift the patient to the COVID ward. So these are certain practical problems which come up in our antenatal patients, which can lead to issues.
Okay, what I would do is the reason what, am I audible?
Yes.
Yeah. What I really wanted Nozer to cover is, he is a person who does a lot of normal deliveries, and in COVID era, how he is scheduling his normal deliveries, how he is scheduling his section, when is he testing, and what kind of PPE he is looking at. So I would cover that in a question and answer session. And Reena is there, Vaidya is there, and this is the all Vidarbha societies are there. So I assume some of the societies, there are not great facilities for testing also. So we need to address that as well. But I would start off with a little bit of my input onto what kind of PPE you should be wearing. And I have very strong views on that, which will not agree to completely with Reena's or Nozer's. The WHO has changed their guidelines so often and so frequently that I think we are better off as medical practitioners in clinical areas, taking our personal protection one notch higher. And these are the points that what people have covered, that screening, thermal scan, but restrict the number of relatives. I know there are private practitioners who stopped allowing any relative inside the consulting room, but we allow one relative. Although WHO would say that if there is, as Reena has said, that is from the WHO guideline, that except for aerosol generation, a surgical mask is enough. I would say please wear an N95 mask in all clinical areas. There are debates going on about micro aerosol generations and etc. Please, as a medical practitioner in all clinical areas, wear a N95 mask. If you can, please wear 2 masks. And as Reena has spoken about alternate chairs being blocked off, and I would say that please use, not only that, please use everything by appointments. Now, what we do in the OPD, I just wanted to say that we wear a N95 mask and a surgical mask, and along with that, we use either a goggles or a face shield. And patients and relatives sit 3 to 4 feet away from the doctor everywhere. That might not be possible, but it is imperative that the patient has a mask on. We not necessarily wear a glove. I think that is a personal choice. I don't wear a glove, but every time I touch a patient, I wash my hands with soap and water, because 25 seconds is very difficult to do with the sanitizer. It requires an immense amount of sanitizer. So whenever next time you sanitize yourself with the microshield, please see how long you are taking. You'll be taking 10 to 15 seconds. If you have to do 20 to 25 seconds, it has to be soap and water. So do that every time you touch a patient. If you wear a glove, make sure you change your glove in between patients. We use a paper roll on the top of bed sheets, which we change after every patient. And surfaces, as Reena said, are cleaned at regular intervals. Now we have the facility like Reena's, that we have in-house testing facilities. So all our planned surgeries, all our planned deliveries get an RT-PCR preoperatively. How soon do we do that? Now, initially, if you remember that there was no pre-op testing allowed, then Foxy lobbied with the ICMR, and the ICMR came with the guideline that women can have an RT-PCR test within 5 days of anticipated delivery. We are still following that. So we are doing 3 to 5 days before anticipated delivery. And this is for cesarean and gynecology ones. And we know that aerosol generation is higher if it is under general anesthesia. So some of us do, if we plan a GA, that we also do a low radiation HRCT, because we all know that 10 to 40% is the false negative rate of the RT-PCR. If an emergency ectopic comes, earlier what we are doing is we are doing a screening CT chest if it was normal, and then we will go ahead with the CT chest. Depending on that, we'll decide how many protection we'll do, how much protection we'll take. At the present moment, we've got a facility of a gene expert. Now, if we do the gene expert, we get a report within an hour. The advantage with the gene expert is that if the gene expert is negative, it is as good as an RT-PCR. If the gene expert is positive, because it has a slightly higher false positive than RT-PCR, you still have to do an RT-PCR. If we plan an emergency patient OT and you do not have the facility to test, and if the OT can wait and you have testing facilities, you admit in an isolation area and do an RT-PCR next day. If it is a life-threatening emergency, no, please operate it as a COVID positive. So that is the same thing that you do if you do not know whether your patient is, whether you do not have a testing facilities. Please assume that every patient is COVID positive and take universal false precautions. And universal precautions should also be taken by us who do testing in view of the false negative rates. So, and I try to simplify PP into 3 groups. There are 3 kinds of precautions. One is contact precaution, one is droplet precaution, and one is aerosol precaution. A contact precaution where your distance with the patient is going to be more than 3 feet and there is going to be no clinical interaction. Here a surgical mask and maybe a glove, like the front of his staff, that would be enough. What is a droplet precaution? When the patient is coming, say approximately around 3 feet, we are talking to the patient, it's a consultation which goes on for some time. And that is where is our OPD precaution. We take an N95 mask. You can put a surgical mask on top of that. You can put a goggles or shield. As I said before, while examining patient, you must put a wear-on or a cloth gown. For ultrasound, Seetha has spoken in detail. Ultrasound is a high-risk area. What is an aerosol precaution? An aerosol precaution is an area where you are having general anesthesia, where you are using diathermy, where you are using nebulization. That is where, apart from an N95 and a surgical mask, a tight-fitting N95 and surgical mask, you need gloves, you need tight-fitting goggles, you need a waterproof full gown or a coverall, and along with that, you need a cap. Now, the last point I wanted to say is that, yes, the GSM, which is gram per square meter, it gives you the thickness of the material of the PPE. If you are procuring your own PPE, the most important thing to see are 2. Number 1, that it is certified either by the DRD or the CITRA certification. Number 2, that it is also written, that I am reading it out, of course I don't have this in memory, that the material has to meet or exceed the ISO 16603 type 3 exposure pressure. Now, our general feeling is that any higher GSM means more thicker. Yes, but what is more important is it will be more waterproof and more resistant if it is double laminated. You can use anything between 60 to 90. The higher GSM you go for, as Reena said, it will be thicker and more better, but it will also be heavier and warmer. Now, the question that I would come to is that now, suppose we plan to do a cesarean section, that it is very easy. What we would do is, I'll stop sharing. What we would do is that we would test the patient approximately 4 days before, 3 to 5 days before estimated admissions. Now, when should we deliver the patient? And if you look at the Royal College guideline, they say that because the first week is the more infective week and the second week is the less infective week, we should try and push the delivery to the second week. The initial publication that came out of New York on their deliveries of, don't remember offhand, 300 or 500, they said that they like to do the delivery in the first week itself, because in the second week, if the disease becomes severe, it tends to become more severe in the second week. So I think our agreement is that, and I would take Reena's comments on that also, that if the patient tests positive and if the patient is asymptomatic and if the delivery can wait, then it makes sense to push the delivery back by around 10 days. Whereas if the patient is symptomatic, then it is possibly better to deliver her in the first week. And there are times if the patient starts requiring oxygen, or if the patient, that is the time when you should consider delivering soon, because if she worsens, otherwise the intensivist would have a problem trying to treat her. Reena, would your comments on that, please?
So I think Bhaskar has summarized it very nicely, and what we are following is like the RCOG guidelines only. And initially, I think even in the whole progression from February to August, there's been a learning phase, and everybody has learned from what has happened in the past. So yes, asymptomatic positive patient with a non-urgent need for delivery or induction, you should wait till the second week. And in fact, by the end of the second week, she is assumed to be negative and the phase is out. And a severely symptomatic patient need to be delivered urgently after maternal stabilization. That is also important. One important point is that need for anticoagulation, oxygen, and ICU admission is also important, which I did not touch upon during my talk. But RCOG has also recommended a routine use of anticoagulation, low molecular weight heparin to all pregnant women near term to be stopped just 12 hours before delivery. We are following this for obese, diabetic, or hypertensive women who are COVID positive. We stop it 12 hours before their cesarean or if they have gone into labor, and we restart it 12 hours after delivery and continue it for at least 5 days postpartum, because this is an important practical point. We have Clexane 60 available in our hospital, but it is something which is worth an investment because blood clots and thromboembolism, particularly with the puerperium being such a period, is something we have to be vigilant about. So I thought I should highlight this because we didn't talk about it in the
no, absolutely. And if you speak to COVID consultants who are practicing COVID, they will tell you that it is a higher risk. There is a problem, higher risk of venous thromboembolism as well as vasculitis, etc. With
yes.
that. The second thing, Reena, is that we've discussed about when would you test if you're planning a cesarean section. There's a question that come in the chat box as well, and I'd asked Nozat to cover this, is when would you when would you test somebody if you're planning a normal delivery? Now, there are two ways to it. Number one, if you do not have a testing facility, do not bother. Whenever she comes in, you will wear a PP and you will do a delivery. If you're planning to do a delivery, what Nozar was going to say is that now if you have the facility for testing, you should possibly test them twice. You should possibly test them once between 36 and 37 weeks, and once you should test them 2 weeks later, so that whenever she comes into labor, you have got a testing status. Now, for example, especially in the tier 1 and tier 2 cities, now tests are readily available. You should be able to get a test report within 2 to 3 days. So it makes sense to test them twice if you are planning a normal delivery. The third question,
yeah. So as what you have said, this is an important point because people can be in the window period of exposure also.
Seetha.
Or in the, hence, in fact, if it is possible to do testing twice, it would be a good option. And in fact, even the ICMR guidelines recommend that the test should be within 5 days of the delivery. That would be ideal. But if you are able, and especially in private practice, patient is affording, and in the third trimester, you're able to do a test at around 36 or 37 weeks, and then repeat it when you think she is going into labor or you are having to deliver her for whatever reason, it would be advisable to repeat it at that time. There's no sense in doing it very early in the first trimester or the second trimester, because that is not going to give us any useful data.
Absolutely not.
Yeah.
And the testing should be an RT-PCR. Somebody said that should we do a rapid antigen? The rapid antigen, I have some good news. Nozar is logging on from his hospital. So he will log on within the next 5 minutes. Till then, we'll finish the question answer session. So the issue is that the rapid antigen test is good in the sense if it is positive, you know the patient is positive, but it has a higher false negative. So if the rapid antigen is negative, ideally you should have an RT-PCR. The second.
So here, I would like to add that in our own hospital, we have now acquired the machine for rapid antigen testing. But the disclaimer which even our microbiology department has said is that please send swabs for both. And they give us the reports for both, and only in the patients who we require urgent delivery. But so the bottom line, I think, which has been mentioned in my talk also, and that you have to universal precautions. How in the time of HIV it came
Absolutely.
about. You still have to do universal precautions even now when you're delivering the patient. When you know she's COVID positive, you will be extra careful. But please remember, just because the swab was negative or the rapid antigen test is negative, do not let your guard down or let your mask fall off.
Essentially, if you're doing a cesarean section under spinal anesthesia and you're not using a diathermy, there is no aerosol generation. So that is where if you have a gown and if you have your N95 mask and maybe a face shield, that's much more than enough.
Yes,
so that is not where you need a coverall. That is very, very important.
So if you don't have a full coverall for the normal delivery, don't feel that this. But what is also important is because of the splash on our feet, the foot covers are important. So the foot cover, a wear on, N95 mask and a face shield is good enough. So this
Meena
will
quickly take another question that has come. That can we give influenza vaccine at 28 weeks in pregnancy? Now, normally we give influenza vaccine much sooner. I personally give it between 12 to 14 weeks. I do not know what Seetha and Reena do, but there were initially some worries about giving influenza vaccine in the COVID pandemic. Any comments, Seetha and Reena?
No, there is no issue in giving, and in fact, I give it to them in the third trimester nowadays. Any
Which
change in practice?
no, we still we give it in first trimester. The initial Foxy recommendation was to give it in the third trimester. That's around 7 years old, and then it was changed to giving it approximately between 12 to 16 weeks, late first trimester. Have I missed any other question?
I think somebody in the chat box had asked a thing that is there an increase in obstetric complications in your COVID positive patients? So here I would like to say there is no association of any increased obstetric complications other than there is a smaller increase in preterm labor, and sometimes it is iatrogenic preterm labor, but this was more in the initial phase when people were more concerned. Now, COVID by itself is not an indication for induction, unlike, for example, PIH, where you might have to do an iatrogenic preterm delivery. Another question which has been asked to me before, which I thought might benefit the audience, is do you give antenatal corticosteroids for COVID patients or not? Now, one thing you must remember that anticoagulation and steroids are in fact part of the mainstay of the treatment of COVID. But diabetes is a comorbidity and the sugars may shoot up. Unless her sugar is completely out of range and she is a full-blown diabetic who is not well controlled, we will give antenatal corticosteroids as indicated. If you think patient is likely to deliver early for any other reason, up to 34 weeks, definitely we would give the antenatal corticosteroids. So that is an important point I wanted to share with you.
By the way, Nozar can start now, I think. Nozar, are you there?
Yes, sir. Dr. Nozar sir is there. I'm adding the co-host also. Sir, you can start sharing the screen now.
So I hope it works this time. Otherwise, you'll have to make me the host again. Yes.
Yeah.
You have this.
Yes, sir, we can see.
Great. So I'm sorry, I was a little distracted because of that patient. And now that I'm right next to the labor room, I'm so I, sometimes I don't know how we weren't better prepared, considering that this was the third coronavirus pandemic that the world has faced since the year 2000. Of course, this one has been infectious like never before. And because of the numbers, the lives lost have been like not that happened in the last two pandemics in this century. And it's time that we accepted this as a new normal. We have to address the mental health. I think most of us private practitioners never really stopped, even from the first day of the lockdown. We continued to deliver our patients. We continued to see patients, albeit in a very restricted manner. I would see them twice a week for the first 2 or 3 months, but I made sure that I saw each patient of mine maybe less often. And the kind of the thanks that you got from them, the gratefulness that you got from them to know that someone was there looking after them. And constantly with Foxy, we were working with the government and telling them that this is an essential service. Lip service was being done. Hospitals were being shut down because there were some infections and stuff. And we told them that where do these patients go? Everything else can wait. The study I told you about is important because I think we have to make that extra effort to go out there, reach out and tell every patient of ours. And the first thing I tell my patients is that while COVID has been terrible for the world, it has been very kind to pregnancies and to obstetricians. And the reason I say this is, you've got to give them something because they are so afraid. Well, unlike rubella and varicella, it's not causing birth defects. Unlike H1N1, where a significant 7%, maybe 8% of mortalities were in pregnant women, it's not doing that. We don't have a vertical transmission as we have with HIV and hepatitis. And fortunately for us, most of the areas that matter to the obstetrician, the amniotic fluid, the breast milk seem to be. I think this has been brought out extremely well. So my talk is primarily going to complement what has already been said by Seetha and Reena. But I'm going to talk about not just managing the COVID positive patients, but how we're going to manage our practices, particularly in the private sector, going ahead with this new normal. Well, I must confess that I don't think obstetrics is a great branch for telemedicine. Yes, you can address questions and minor ailments, which we've always done. Yes, we can do ultrasounds and visits in a way that they don't have to get out. So what we did was dual marker, anomaly scan, 28 weeks growth scan, and then meet at the very end. So instead of meeting every fortnight, maybe we were meeting once a month with constant access given to them for everything else. But at 36 weeks, we do an ultrasound and an NST. And here there is a very practical issue. Reena mentioned the desirability of doing a COVID test just before delivery. But the point is that for private hospitals, this is mandatory. They have mandated that a COVID test get done before delivery, and that delivery has to happen within different hospitals at different kind of time frames. Usually it's about 7 days. What do I do? Well, I we would
Nozer sir, you are not audible. I think there is a network issue at your end.
We would do our standard prenatal exercises in preparation. Can you hear me now?
No, sir,
Hello?
the voice is breaking.
Hello?
Yeah, now better, sir.
Okay. Can you hear me now? Hello?
Yes, sir, we can.
Sorry. Yeah. So the testing is now being mandated for all the institutions I work in, and I think for a majority of the institutions, many of the people on this call would be working in. When you look at the recommendations by FOXI, when the recommendations by the ministry, well, they initially said if they come from clusters, large migration gatherings likely to deliver in the next 5 days. And I think at this point in time, the biggest fear is where does the test get done? Fortunately for us, at least in Mumbai, we are able to get these tests done very easily now, finally. It wasn't like this a month ago. Home collections are possible. I find it very easy to do it in a hospital setting itself. We just call our patient when she needs to come and do the test. And we also have a very interesting drive-through testing facility, which my patients somehow are really taking to nowadays. And I think that's something they feel very safe doing. Recently, I've started doing repeat testing because I tried to fine tune it so they just needed to do one test. And then I had a few patients where the test wasn't done. And at that point in time, they came to hospital and then we had to treat them as COVID suspect patients. And in fact, 1 or 2 of them actually turned out to be COVID positives after we delivered them. I think the tests have been discussed, and the only test that is acceptable today is the RT-PCR. I agree that you've got false negatives in 10 to 30%, but what I want to stress here for practitioners is excellent specificity, right? So you aren't going to misdiagnose. A lot of people and my patients tell me that could these tests be wrong and could they be diagnosing a positive test when she doesn't have the disease? No. Specificity, excellent. Sensitivity, not great. 10 to 30%, 35%. And here again, as I tell my hospital management and colleagues, that we need to be careful with each and every patient. And I know this is sometimes a little kind of be giving it too much importance. In fact, for all the non-obstetric patients, they are now insisting on doing a CT scan and HRCT for these patients, which I think is a bit of an overkill. So we need to do these tests. We need to do them at the right time, but we don't take our guard down even if the test is negative. Rapid antigen testing, exciting. Let's wait for it to become a little better. Maybe it would help us identify the positives in a matter of an immediate test, but negatives would not be so dependable. And let's look at serological testing. In fact, I'm just doing a little trial in my own private practice where I've started doing an antibody test at the 28-week investigations. And maybe in 2 or 3 months, I will know what's happened with my patients. Now, this is not a small number. I just checked. I delivered 80 patients since the day of the lockdown, out of which I've had 6 patients who were positive during pregnancy or who had to be delivered while they are positive. Now, for a private practice, to have a 7% a very safe private practice. And I can tell you, my patients have been very cautious, very careful. That's not a small number. The total number of patients today has touched 17. Yes. And of course, some of them were contacts, 6 contacts, after which 3 have turned antibody positive, which meant that even those patients actually had the disease. This is something that we are all going to have to deal with, no matter where we are practicing and with what patient populations we are practicing. What do you do? Well, triaging is important. I think Reena has done it beautifully. I'm not going to get into that, but I can just tell you here that a lot of what I'm talking about today is the guidance or the guidelines from the Society for Maternal and Fetal Medicine. I'm also referring to FOXI, ICMR, and the other guidelines, but these people have done a fantastic job. And the Society for Maternal and Fetal Medicine, I believe, does the best evidence-based guidelines probably when it comes to obstetrics and antenatal care. So they said acute obstetric concern in labor and stuff, then obviously we have no choice. We have to go ahead with the labor and delivery evaluation. You do your COVID testing. And then, of course, even if the test is not available, take care of the patient with appropriate PPE. Decision has to be time sensitive. And if your patient is not symptomatic, as many of my patients are, as a patient who called me up today, who was to have been for a circulage tomorrow morning, we got a test for her yesterday, and she is an asymptomatic, tested positive. Home isolation, I'll test her after some time. I've told her to stay out of circulation for 2 weeks. And as has happened with other patients I've delivered to date, I find that most of these patients have absolutely no complaint. After some time, they are fine. And after adequate time, they can come back into your practice. If there is urgent obstetric issues, labor, PROM, vaginal bleeding, in this, you have to have a section dedicated to patients. If your hospital can't have segregation, then maybe you should know what you can do and what you can't take. So 2 of the hospitals that I work in actually have COVID patients and sections, and a third doesn't. We segregate patients into 3 groups, physically, by staff, and by management. The first group is the COVID negative. We have a test. The second group is the COVID positive, but the COVID suspect patients deserve to be kept separately. Unfortunately, people push them into the COVID wards, and I think that's really unfair when you're dealing with an antenatal patient to do that. Do you screen the partners? I don't think so, though in one of the hospitals where we still have the partner coming into the labor room, for hospital policy, we do screen the partners, and it seems to be working out well. General labor and delivery protocols, well, common sense. Everyone wears a surgical mask, every patient and every provider. We have limited, all hospitals have limited visitors to 1. And I think this is something we probably need to carry on for a very long time. One of my hospitals, the anesthetist has come up with a very little clamp on the IV stand. So the husband is there talking to the wife and seeing the delivery, though he's not in the room. You've got to have ideas such as this, because like I said, this is the new normal. And while hospitals don't allow switching of visitors, I think that's really unfair, particularly when it comes to patients for delivery. And the reason why I say that is, I want the husband there at the time of the birth, but very often the woman needs maybe her mother to be there for the rest of the stay. And I think if the person is staying in the room and following all precautions, and she's been physically triaged and she's wearing a mask, and I don't see any reason why this should not be allowed. Level 3 protection, again, Reena has brought it out. If you've got aerosol generating procedures, particularly that includes the second stage of labor, surgical cap, face shield, an N95 mask. You may or may not wear the full kit depending upon whether the patient is diagnosed or suspect, but otherwise you definitely don't need to wear a full PPE. Latex gloves, 2, some people use 3, and a full face protective shield. Now, I think we need to be rational with PPEs. I know we now have enough PPEs because everyone's manufacturing that. And it bothers me when we start irresponsibly using PPEs because of the fact that not only is it adding to a lot of cost, it's also adding to a lot of waste in the environment. And I think Reena will tell us how when they work on those scales, particularly in public hospitals, the mountains of PPE kits in the bags they are creating, I mean, it's all going to go into our environment. So while the pandemic has made the environment better in one way, in other ways, we are going to make it worse. I remember early in the pandemic doing a very, very minor procedure. I think it was Mr. Boston. I did an MVA. And I remember because of hospital policy back then, we actually used 5 PPEs. And I thought that was a terrible waste, particularly when PPEs were in short supply. What about drugs that we commonly use in pregnancy? Well, indomethacin has been used. I do use it for tocolysis, particularly after a cerclage. There is obviously a hypothesis that since the virus binds to the cells through the ACE2 receptors, NSAIDs may not be a good idea. And early reports said that NSAIDs might worsen the condition. I think for tocolysis, think of alternatives, and nifedipine is an excellent alternative that we need using even otherwise. What about betamethasone, dexamethasone, antenatal steroids? Reena touched upon that. There is evidence from other disease pandemics, the MERS, that showed that there was a delayed viral clearance with steroids, and the systemic steroids could increase the morbidity of viral pneumonia. Having said that, the benefits of antenatal steroids are so great that use them judiciously, use them well, but they definitely will be needed if you are likely to deal with prematurity, which in this case is very often going to be iatrogenic. We need a dedicated delivery room at the Holy Family Hospital. We've converted one simple patient's room into a separate delivery room. It doesn't need to be fancy. Okay, we've got a very simple delivery table here. We've got the neonatal resuscitation there. We've got our oxygen. We've got a simple light, and you'll need a place like this. And you need this, there has to be inter and intra-departmental segregation. You have to designate room, section of floor. You do not need a negative pressure room for obstetrics. So let's not get too carried away. Otherwise, hospitals would not be able to give whatever care we normally do. Remember, I'm not just talking about the actual COVID positive patients. I'm talking about our practice going ahead. What about the role and use of induction of labor? Well, if I'm doing many more inductions today than I did before the pandemic, because I have this 7-day thing. So I wait, I get a great Bishop score. Once I get a great Bishop score, I do the test, and then I take an induction, and it works out really great. You have the option of beginning the induction process at home, but I think in our situation, I want her in hospital. I do use mifepristone. In fact, the patient who's going to deliver now had not a very great cervix. She's post-dated day before yesterday. It was tubular, just maybe 1.5 centimeters. Mifepristone 2 days ago in the evening. Today she came 1 pg/E2 in the morning, and everything's going great. And of course, I do not use this for induction, but I constantly get reminded that the evidence is great for the Foley's catheter inductions. And I did use it for 2 patients in the last 3 months. One was a previous 2 LSCS who had an IUFD at about 23, 24 weeks. She did not want a surgery, which she had been recommended. And after years, I did an extra amniotic. I just instilled saline through the Foley's catheter, put in 15 methyl F2 alpha, 1 cc diluted to 10 cc's after 6 hours. Beautiful. It just went great. I actually find the pain factor is a lot less than the misoprostol we use, though I must say that routinely it will be misoprostol. Please do not be in a hurry to do a C-section. Please remember that the C-section procedure probably puts everyone at greater risk than a vaginal delivery, even if it's a negative patient. And they said that, again, this is a recommendation by Bergella, who says that C-section does not need to be performed at least 15 of oxytocin and amniotomy done, and you do it only if absolutely indicated. First stage of labor, there's no need to alter it. Oral administration of water clear fluids continues. If for some reason there is oral restriction, dextrose IV can be given. Oxytocin augmentation has been recommended shorten time to delivery if there is a slow progress. For God's sake, the partogram has to be used so at times like this, so you know how the labor is going. They have shown that at this point in time, early intervention with oxytocin and amniotomy would prevent dysfunctional labors and slow labors from happening. Cesarean section for arrest of the second stage, the recommendation is that if you've got an arrest for over 4 hours with adequate and 6 hours with inadequate uterine activity with rupture of membranes, oxytocin, and a cervical dilatation over 6 centimeters, consider doing a C-section. What about the obstetric analgesia, touched upon before. With these patients, this I've always believed epidural is probably one of the best things to happen to women, more so now. Early epidural minimizes the risk of GA if there is an emergency section, and neuraxial anesthesia is not contraindicated with COVID. Nitrous oxide, in our hospitals, we have Enternox. We've decided that we're not going to use it now. And at least for the next few months, we're going to put those cylinders aside, because that kind of, the person holding the mask, the patient breathing in and out with that kind of, even if she's a so-called negative patient, I think we can do without it. So it's best that we eliminate that use. In fact, it's also recommended that oxytocin via nasal catheter, which we often use as a kind of an antenatal resuscitation, is not recommended. Firstly, because intrapartum oxygen is honestly shown to have no fetal benefit by evidence, and we just use it a lot. And they said just avoid doing it. Avoid doing anything that causes you to go close to the patient's nasal passages. Second stage of labor, there's no need to alter from the routine. Pushing does not need to be delayed. It just increases time to delivery and PPH. An assisted second stage likely to be necessary. I'm liberal with the use of instrumentation more so now, and nothing changes. A perineal massage, I do not do routine episiotomies, and you can minimize your tears with care at this point in time. What if she's a COVID suspect or a COVID positive patient? Then you have to have your full droplet protection. You have to have your N95 mask, and don't have too many people in the room. Sometimes our labor rooms tend to be overstaffed. And this is the time when you have to have each and every staff member completely justifying their role. They just can't be there. Anesthetist has an assistant, the obstetricians has 2 or 3 people, the nurses have, we don't want that anymore. We want to keep the staff to bare minimum. What about the COVID suspect or positive patient? We'll keep a watch on our oxygen saturation throughout, a continuous electronic fetal heart rate monitoring. You'd probably have to have a dedicated monitor, because this monitor can't walk in and out of that labor room, which is looking after COVID patients. Of course, it's got to be sanitized and taken care of and covered, and you do all this stuff, but be careful. They say the mode of birth is not influenced by COVID unless there is a dramatic deterioration in the respiratory condition. Epidural analgesia recommended, and of course, an individualized decision to do an instrumental delivery. This is there in that article I'm going to show you at the end. It's in the American Journal of OBGYN this year. And this tells you as to what kind. I've just put 5. There were actually 7 of these columns. And I'm just going to highlight 2. For the obstetrician, double or triple glove, ensure no contamination while removing PPE. Reena stressed this. I was told by a friend of mine who looked after a number of patients whenever of COVID positive patients, when she advised me, when I was to look after a patient, doffing is probably the most critical step, okay? This is the time we need to take very seriously all that we knew about, but usually didn't practice when it comes to how we wash up, how we gown up, and how we doff. And post-operatively, that is extremely important. Now, I'd like to share with you this video. Mumbai Society had a fantastic conference recently called Youngistan. Every person in that conference was a young person, and they all did these 1-minute videos. And so my son was one of the guys, and he put together this video on doffing. You know what a difference it made to me when I did my next COVID positive C-section? Because when you've seen something like this, when you see how systematically you first put on gloves, you go step by step, you take your leggings off first. At every step, you keep sanitizing your gloves and your hands. You have to give this a lot of thought. This is when, if you've been in a contaminated field, if your gown is contaminated, if your head covers and face masks are contaminated, we run into trouble. So this, as was told earlier, we have to have a decent doffing room. It can't be too small because you need space to move. You need a place to put all these, whatever you take off. It's got to be an adequately large container, considering how much happens. And then the last thing, of course, you do is you take off your glove. That additional, if you take your first glove, put on an additional glove, and then you take off your gloves. And this probably is what will prevent many people who have gotten infected at this stage. Third stage of labor, this is the time to conserve blood because blood donation drives are not happening. So for God's sake, make sure your patient hemoglobins are great. This is the time to also use parenteral iron if you feel you need to. If you need blood, please don't just send for 2 units of blood, send for 1, because the blood banks at the moment are definitely finding it difficult to get blood replaced. Besides standard oxytocin, it has been recommended that you can use prophylactic tranexamic acid and buccal misoprostol to again conserve blood and prevent blood loss. And in institutions where they have facilities, we don't. But this is again the Society of Maternal Fetal Medicine. They've suggested that cell salvage if possible, transfusion if you need it, please start off with just 1 unit. They recommend the delayed cord clamping to be avoided, though vertical transmission has not been confirmed. I've always believed, let's not have extremes. Don't clamp immediately and don't wait for a very long time. It's always safe to be somewhere in between, something like 30, 40 seconds to 1 minute before you do your clamping. Neonatal consequences, the good news for patients, no increased risk of miscarriage, no evidence there is fetal growth restriction. What about babies being infected? This UK obstetric surveillance system of the University of Oxford said the mean age was 38 weeks. Preterm births were 27%, of which half were iatrogenic. Okay, so let's not make this mistake of delivering babies early. And a positive test in this series of patients in the first 12 hours was 2.5%. Another study of 71 patients where there was diagnosed COVID in the 3rd trimester, 5.6% had neonatal infection. And I think this is extremely reassuring for us and our patients. Rina's touched upon neonatal care and lactation. And here I think we need to keep our heads and our balance. The initial American Academy recommendation was minimize likelihood of infant being infected. And ICMR said the same. The updated recommendation is give them the option, allow rooming in if they want to. The mother has to practice very, very safe, distancing, gloves, masks, and the isolate. That's a picture of the isolate Rina mentioned. Hospital staff to wear an appropriate PPE. One of the hospitals I work in, infected.
Sir, you're not audible.
Judge.
No, sir, you're not audible.
Hello.
So there is a lot of.
Okay,
Hello?
can you hear me?
Now better, sir. Yeah.
It's fine now. Hello.
Yes, sir. We can't hear you now, sir. Oh.
I think it's a network problem at his end.
Sir, you muted yourself. No, sir, you muted yourself.
No, he stopped sharing also. He has stopped sharing also. I guess the connection
I think it's a network issue.
Yeah, he started sharing. Yeah.
I'm sorry. Came to the hospital, so Bhaskar had to go to my hotspot again. I was at home for the Wi-Fi. Okay. I've just got 2 or 3 more slides. So vaginal deliveries, they've said early discharge, C-section, 2nd day. We are sending patients home, though 1st day after vaginal and 2nd day after C-section is not really something we can do easily in India. Postpartum visit, we are not calling patients back in a week. We try to have them call in and reassure them. But I now have started calling them after 2 or 3 weeks because they need to see us. And then I don't call them till maybe 5 or 6 months. What about contraceptive choices, new way of practice, new experiences? This is where telemedicine, according to me, is extremely health friendly. So if a patient can't come to you, please do not forget to do your contraceptive counseling. It could be barrier contraception with the backup of emergency contraception. It could be using the progestogen only pill. They don't need to come for that. Or it could be an injectable, which you could do early and protect them at least initially. Maybe this is the time to promote postpartum IUDs when you don't want them to come back. And I feel always that we've never really taken to this in the private sector, and we really have it taking off and being pushed in the public sector. I would be happier if we can prove in the private sector that postpartum IUDs have been accepted, and this is probably the time for patients to be accepting it, because then they don't need to come back. If you're doing a C-section and you need to do a concomitant tubal ligation, please don't postpone this just because we are dealing with a pandemic. So this is what we need to do as far as contraception is concerned. There's so much resources, but these resources, one is Foxy has done such an amazing job. These last few months, I know these have been difficult times. Every president has his year planned out. His vice presidents are going to do so much, but we have really proved ourselves to be the organizations, to be there working for our members and women. We have the second version of the Foxy GPR. RCOG, I just love anything they put out because it's so practical, it's so practice oriented. The labor and delivery guidance of the Society of Maternal and Fetal Medicine. And the great thing about this time is that a lot of the COVID related resources are available online free of charge. You know, these days they've just kind of made everything not available. And finally, the ICMR guidelines. Please download these on your smartphones, on your smart devices. Read them all the time. It will make a big difference to your practice. Finally, I'd like to quote two people who I admire greatly. The first is Atul Gawande, who has written, "The new normal is to learn from each other and learn at hyper speed." I think that's what we are doing. People say we are having too many webinars. Of course we are. But then there is a choice. You pick and choose which webinar you want to attend. And we are sharing information like never before. I don't need to go to Nagpur Society in Vidarbha to speak to them. I can do it from my home and from the side room of the labor room.
Yes,
And everyone's learning. And finally, Sanjeev Puri, who heads ITC, which is one of India's most remarkable companies, said the longer we take to adjust to the new normal, the more stressful we make the situation in the long run. Please work hard to adjust to it now. Sit with your staff, sit with your assistants, look and constantly keep reviewing and changing your practice. Take the help of friends. For me, Atul Ganatra is a friend who's a champion in these things. Parikshit Tang, of course, they are the ones who work with Alpesh. Well, today in our OPDs, I have an N95 mask, all my staff does. We have a face shield, all my staff does. And we wear a washable half PPE. And in spite of having 17 patients who have contracted the disease or at different stages of disease, thankfully, as of now, we've all stayed safe. And I hope that all of you will stay safe as well. Thank you.
Thank you, Nozer. I think the big point is that the webinars have made education more equitable. You don't have to have a lot of money to go to a good conference and pay registration fees and arrange your travel and etc. I have two questions. One is from Dr. Vijay Lakshmi, which we will not answer because I think nobody knows the answer. Her question is, when is the ideal period to check for antibodies and what is the percentage of patients who will have antibodies? And after mild infection also, antibodies will be there or not? I guess we are not clear of that. We have one of our colleagues of many, I will not name, whom most of us know very well. She got reinfected in a month's time. First time a mild asymptomatic infection, second time a severe infection. The second question I'll take.
Bhaskar, can I try to answer that question?
Yes,
There is a large study of antibodies being done in the Municipal Corporation of Bombay, which is headed by the Molecular Biology Lab at Kasturba, to see whether there is IgG, IgM antibody positivity, and they are testing. And the inference from a high titer, there is a titer level of antibodies. So in fact, if you have got antibody positive, they are inferring that it is probably going to give you protection from reinfection by COVID for at least 2 to 3 months. But as you mentioned, the jury is still out on this, and
Absolutely.
they have done almost 5,000 cases, and they are looking at analyzing the data.
I think everybody is saying that, but what people are not sure of after an asymptomatic infection, whether everybody will develop antibodies, and even if they develop, how long it will take. That's the key question. A question Dr. Soumya has asked about 3M respirators, whether these can be used. Now, please remember, when it comes to personal protective equipment, I would like to make a quote that there are two things in life which have no limits. One is greed and one is fear. So essentially what we have tried to say is that what you need to do enough to protect yourself. Nozer said about his unit. In our department, we've operated on 12 positive patients, including 2 patients who initially were negative and post-operatively turned positive. We have innumerable number of patients going through our OPD, and none of our staff have tested positive. So the sort of protection that we have advised is from that point of view. Yes, N95s you can reuse. There's a EMS protocol. If you can follow that, you have a set of 4 N95s, and each you can use for 5 days. So 1, 2, 3, 4, 1, 2, 3, 4. So every one you use for the 5th day. And if you are like Seetha or Nozer, who are very absent-minded, please keep 7 of them in 7 envelopes and mark them Monday, Tuesday, Wednesday, Thursday. So at the end of 5 weeks, through all 7 of them. So,
but Bhaskar, here this is important. This is if you have done a surgical procedure or the mask has got wet or has been exposed, then the mask needs to be disposed. This is only when you have used the N95 in other settings where you have used it for your extra protection, where it was actually not a level 3 situation. And I think one of the chat boxes had asked about reusable masks. There are these washable masks in the market, which are being recommended that they can be washed and reused for up to a month. So these are cloth masks with layers which are supposed to be, but these are in the other settings where you would, instead of a triple layer mask, you're using this. These kind of reusable masks could be considered, but we would not consider using them in our surgical procedures like cesareans or for the labor.
Yeah. What Reena has said, not only I'll add to that, if the mask is visibly soiled, or even the CDC said if you use the mask for a COVID positive patient, then do not reuse it.
Yes, absolutely.
The second point is that somebody is asked whether you can reuse the respirators. I guess you mean the ones which look like Star Trek. Please remember they have a reusable filter. So the rule is the same. There are some people who are saying that if you have a COVID positive patient, the filter might catch the viral particles. So even if you use those respirator masks, you need to follow the same regimen. That which means you need to have a set of 4 respirators and you use them every 5th day. As I said, that fear has no limits, and there are now people who are using the 1,40,000 respirators which have an oxygen supply in them. I know a bariatric surgeon in Calcutta who's using them. I know people who are using them. But an N95 mask with a surgical mask will keep you safe, along with a face shield or a goggles, and you can keep on reusing them unless it is soiled or unless you've come in contact with a positive patient. I think we've answered all the questions, and I will hand it back to Vaidehi. But before I hand over, I must say that Vaidehi and your team, you have kept us as perplexed, and not only innovation, dynamism and enthusiasm. And I think it is time, I have told this to Vaidehi, that you need to step out of Nagpur and move into the state levels or the national levels. I think any organization will do great with your leadership skills and innovations. And
thank you so much, Dr. Bhaskar. This means a lot. It's all a teamwork finally. So thanks for these encouraging words. Thank you so much. Sir, we also have Dr. Gitendra Sharma with us, who's the chairperson of Medical Legal Ethics Committee, FOXY. Sir, would you like to give some inputs about the medical legal aspects of the entire scenario right now?
Good evening, madam, and thank you for acknowledgement and giving me this opportunity to interact with all stalwarts of FOXY, Dr. Nozer, Dr. Reena madam, Dr. Bhaskar, and sir has rightly said, the first webinar I attended with the Nagpur Society, and from that day I admire the team of Dr. Vaidehi and Dr. Rajsi. So they are doing exceptionally well. In reference to COVID, I don't want to speak much because now we are too much late, already near it. So I will tell only 2-3 things that to avoid problems, we should consider all the patient COVID positive and do our practice in this pandemic. Second thing, to protect yourself, documentation is most important. So even if you are washing the floor of your hospital 4 times in a day, so you should keep a register and you should enter that in your register that you are washing at particular time, so that in court of law, if something will happen, suppose some patient has said by Dr. Bhaskar sir that 2 patients became positive after the treatment. So if the question will be raised by such patients, then you can protect yourself by showing them bills of purchase of your mask and hand sanitizer. So whatever you purchase, you keep the bills with you as a proof that you are using them regularly. And last but not least, that you should prove that you were diligent enough in the practice. So you are maintaining social distancing. You should put a few posters for patient education. You can give your staff training, and that training is also to be put in one register that your staff was given training. And so if you will keep such kind of documentation, then there will be no problem, even if some patient will become positive after entering your hospital. So thank you very
so
much.
once you had, Gitendra sir, once you had mentioned that before you begin the surgery, take a picture of you and your staff wearing the PPE and hand it over. Is that what we are supposed to follow?
Not required, not required.
Not required.
Such things are not required.
Yeah, it was mentioned in some webinar.
Follow the GR issued by the local appropriate authorities. Because we are supposed to, according to Epidemic Disease Act, the local appropriate authorities have vast power. So whatever GRs are issued by the state government or by your local appropriate authorities, you are supposed to follow that GR. Otherwise, you can be held liable under IPC section 188, we all know. So everybody has become now master. So nothing more to tell about.
Yes, thank you so much, sir. Dr. Seetha or Dr. Bhaskar, sir, if any one of you can take this, someone wants more information of UV light sterilization.
UV light sterilization.
Yeah.
I don't have much experience regarding this, but I think it's available on, in fact, on Amazon, and you get these small sort of filter boxes. Yes. You can just buy it, and you can put those things, or your goggles or your glasses or your iPhones and stuff like that. You can put it in there. But personally, I don't have any experience for this. Yeah.
I think we are done with most of the questions. There was one question which was left. One moment. Respirators is done.
Yeah, respirators. Ideal period to check for that is also done. Yeah.
That's also done. Yeah. I think, yeah, that's the end of the Q&A session, because I think the questions, almost all the queries were well answered during the deliberation. The questions are many. Yes, there will be a recorded link. We'll be uploading this recording on our website in 2 days' time. So do visit our website. You will get the recording of today's session also. Over to you, Rajasri, because it's almost 8 o'clock and we need to wind up. Yeah.
Yes, definitely. Thank you, ma'am. It has been a wonderful evening, and I would like to give my sincere thanks from Vidarbha societies to the esteemed galaxy of faculty we had today. The pleasure of hearing all the stalwarts in one go, starting with the chairperson ICOG herself, Dr. Mandakini Megh ma'am. Thank you so much for your valuable words of guidance regarding ICOG, its importance, the fellowship, and how easy it is to get ahead with it. Really, ma'am, you have made certain extremely wonderful transformation to ICOG, and I hope many more people will step ahead and make use and become FICOGs in the coming days. Thank you so much once again. I would like to thank the other speakers, Dr. Seetha Ramamurthy Pal, Dr. Reena Vani, and Dr. Nozer Sheriar, for their wonderful deliberations on a topic which has been haunting us day in and day out. I think now we feel much better to handle ANC cases with COVID positive situation. Also, Dr. Gitendra Sharma, thank you, sir, for your special input regarding medico-legal aspects of this COVID. Your few words of wisdom were really appreciated. Thank you so much. Special thanks to the chairpersons of today's sessions, Dr. Bhaskar Pal, Dr. Nilima Ardak Thakare, and Dr. Kiran Gupta. Also, I would like to thank Dr. Kirti Sane, Dr. Poonam Verma, Dr. Anita Kotwal, Dr. Lata Agrawal, and Dr. Shruti Sune, who have wonderfully introduced today's faculties one by one. Thank you so much to all the participants who have always been with us, supporting and encouraging us, logging into our DGO Gyan online CMEs, and giving us your valuable feedback. We really appreciate and want you to be with us always. As I have already posted, ICOG has always been very kind enough to grant 1 ICOG credit point to our online CMEs. Those of you who wish to seek these credit points may please send us your details, name, registration number, your mobile number, and your email address to any one of the numbers which I have posted in the chat box, and I shall post it again. Ma'am is already sharing.
Rajeshi, am I allowed to ask a question?
Yes, sir, please.
To both of you, why do you call it DGO GAN?
Sir,
digital GAN.
Digitally, we are offering GAN to everyone. So
no, what does the O stand for?
Just rhyming.
Obstetrics and gynae.
Okay.
So O and G is that O and G, GAN of G. So it's OG.
Okay.
That's an interesting one. Nobody ever asked till date. Thank you, sir.
Thank you.
So you can send your details to any one of these numbers right now on your screen. You may take a screenshot. And for future notifications of our DGO-GAN CMEs, please send us your name and mobile number to our office number at 93566-32671. It's on your screens right now. You may take a screenshot. We'll add you to our broadcast list and we shall be sending you the future notifications. Thank you once again for everybody being with us and being a part of our DGO-GAN journey.
Thank you.
Hope to see you
Thank you.
soon
Thank you
again.
for having us. Very tech
It's a very
savvy
good
society, you must say.
Thank you so much.
Thank you so much once again. Thanks.
Sir.
Nilima, go ahead.
Yes, and thank you, Gitendra sir, for the last moment entry. Thank you, sir.
Thank you, Nilima madam.
It's always better to end with the medico-legal aspect.
आखिरी का स्पाइसी तड़का रहता है मेडिकल.
हाँ, वो medico-legal से आता है.
Yes. So I think it's quite late today, 8 o'clock already. So quickly we'll end the meet. Thank you once again, Dr.
Thank you,
Bhaskar sir.
everyone.
You were a great help to me in organizing this session on COVID
Thank you. My
management.
pleasure.
So he helped me through the faculty and everything. And Dr. Seetha ma'am, thank you so much.
Thank
So
you.
on the panel, I'm calling you ma'am, but I promise you to call you Seetha. Thank you so much once again. Gitendra sir,
you.
thanks once again.
Thank you.
Thanks everyone. It's bye-bye from Vidarbha Societies of OBGY Societies. Thank you so much. Have a
Thank
great
you and good night. Thank you.
good night. Thank you so much.
Bye, Vaidehi. Bye, Rajeshi.
Bye-bye.
Bye, Gitendra. Bye.
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 Bye, sir. Good night.
Good night.
Stay safe. Yeah.
Bye, Rajeshi.
Bye, ma'am.
Adisi, can you post our website link, because
Yes, ma'am.
again people are asking
Yes, ma'am.
sending me
I'll
private
just do that.
messages. Yeah,
I'll
so
just do
friends,
that.
Rajasi will post our website link also in the chat box. Do check that out. Also, if you visit our Facebook page, you will get the link to our the messages that we circulate has our Facebook link as well. So on our Facebook page, you will get the link to our website also. But Rajesh is posting the website link. Don't post your name, address, phone number in the chat box. We have shared the numbers. We have shared our office numbers. Send your information there. I'll share the screen once again. So for ICOG credit points, quickly take the screenshot. You have to send your information here on one of these numbers, not in the chat box. We won't be able to retrieve the chat after we end the session. Quickly take a screenshot. This is on one of these numbers. You have to send your information, that is name, registration number, email ID, and your mobile number into one of these numbers. This is the number for ICOG credit points, not in the chat box, please. And Dr. Rajesh is also posting in the chat box. She's posting the link to our website. Next time, I think I'll make a slide of our link as well. And this is our office number. If you want to get notifications of future DGO GANs, then you have to send a message on this number. Just send your name and ask us to be added in our broadcast list. So this is the NOGS number. I hope you've taken screenshots quickly so that we can save time. So this is the number, office number for notifications, and these are the numbers to avail ICOG credit points. I think I should stop sharing now. Enough time has been given.
Yes,
yeah.
ma'am.
Right. So I'll just wait for 2 more minutes so that you can, in case you have missed on the slides, Dr. Rajesh's is the last message in the chat box. Quickly take a screenshot of that as well. So you'll get the link and the contact numbers for ICOG credit points and also for future notifications. Thank you once again. In spite of being so late, it's 8 o'clock already, more than that actually. So people have still stayed on. Yeah, just 40 people logged in now. I think we should end the meet.
Yes, ma'am.
Thank you, Sane madam. Nilima Geli, Atul, thank you so much. Thanks, Shruti, for joining in at the last moment to, yeah, thank you. Tumhe OPD dat ka?
मी ते स्क्रीनशॉट नाही घेतलाय नंबरचा.
तुम्हाला हवा आहे ना? मी शेअर करीन आपल्या त्या ग्रुपमध्ये ICOGच्या.
चालेल चालेल. थँक्यू.
छान. या
खूप छान झाली. आजचे वेबिनार खूप छान झाले.
खूप युजफुल होती. खूप छान.
हो हो.
या
चलो.
येस.
चलो बाय.
थोडं बहुत मॅडम, काही नाही, तुम्ही सगळे सोबत होते म्हणून फटाफट झालं.
नाही चलो ठीक आहे बाय. छान झालं.
थँक्यू. शुड आय लेट द मीट नाउ?
Yes, ma'am.
Yeah. चलो, बाय एव्हरीवन.